So for those of you who I haven't met before, my name is Dr. Lisa Gantz. I'm one of the co-leads on our AAP CA2 chapter's Immigrant Health Committee. And we are so honored and excited to have our amazing guest speaker today, Dr. Karina Anaya. We are co-hosting this event with the Refugee Health Alliance, an incredible group that you'll hear a little bit more about in a few moments. I just want to confirm everyone can hear me okay, yes? All right. So I'm going to do a brief introduction and then turn it over to Dr. Anaya. The format for our session this evening will be about 40 minutes of overview and discussion led by Dr. Anaya. Then we'll have about 20 minutes at the end for open forum for questions. Feel free to post questions in the chat and we will address those at the end. It'll be a facilitated session, but you guys are welcome to unmute yourselves and speak up if you feel comfortable, or I can read your questions out if you'd like. Dr. Karina Anaya completed her general and child adolescent psychiatry training at LAC USC Medical Center. Her parents are immigrants from Mexico and Argentina, whose histories helped her weave a sense of belonging to a global community. Karina specializes in LGBTQIA2S+ mental health, chronic pain, trauma, and minority stress. She completed a transgender youth psychiatry fellowship at Children's Hospital Los Angeles in 2022. She is passionate about decolonizing mental health and treating patients from an anti-oppressive framework. Since 2019, Dr. Anaya has been regularly volunteering with Refugee Health Alliance in Tijuana, Mexico. For those of you who aren't familiar with it, Refugee Health Alliance has been serving migrants and other vulnerable populations at the U.S.-Mexico border since 2018. RHA currently assists in the provision of medical care for over 30 shelters and at 2 clinics in the center of Tijuana, Resistencia en Salud and Justicia en Salud, offering services including general medical and pediatric care, LGBTQIA+ care, prenatal and midwifery, dentistry, women's care, acupuncture and naturopathic medicine, medical legal services, and of course mental health services, as well as services addressing social determinants of health. So it's my great pleasure to welcome Dr. Anaya, and thank you all for joining us this evening. Of note, this session will be recorded, and please do keep yourselves muted unless you're asking questions. Thank you.
Hi, everybody. It's really nice to be here. Thanks so much for having me and giving me this opportunity to chat with you all. I like to keep it informal. I know we're like a slightly bigger group, but I'm also open to like interruptions and stuff, but I also am trying to be mindful. Sometimes I speak fast because I get nervous, so it's okay to like slow me down with a question here or there. I'm totally fine with it. So, yeah, so the goals of the day, I included some Spanish in this so we can practice our Spanish too, some like loose translations. So metas del día, but really we'll just be kind of talking about trauma-informed care in medical settings, how to handle like overwhelming emotions quickly through psychological first aid, and how to motivate people to try out maybe some mental health services. So hopefully this is helpful to you all. I'm not sure exactly like what level of like experience you all may have already had with psychological first aid. It's really like a layman's tool, but it's really great for us as providers to also have those tools, or at least the framework to utilizing it with our patients. So some of the principles of trauma-informed care, really, I want to start off by just briefly introducing some of these principles in working with a highly vulnerable population, especially those that have been displaced. They're likely not only to experience trauma along their route of migration, but also highly likely to have experienced pre-flight trauma, and as well as additional difficulties when they land in their host country. So adopting a trauma-informed approach to your patients as well as to your colleagues, right, creates a culture of psychological safety. So we want to promote or create a setting that is non-threatening, non-institutionalized if possible. So collaborating with other professionals, right? may be some of the most effective advocacy that you can do for your patients, right? Helping them really kind of navigate our really complicated healthcare system. Transparency, so being transparent with patients also helps foster that sense of safety, as they are constantly seeking confirmation that you are a trustworthy person, or maybe someone not to be trusted, right? So it's really important to maintain transparency with our patients. And then for, as well as for us, like seeking peer support, so supervision is really important. You're not alone in this. It's not really going to be a sustainable practice if you're taking on this work alone. So really don't be afraid to like seek out supervision or take time for self-care. And then lastly, the goals of good practice is to involve the patients in the treatment process by empowering them to take control of their health to the best of their ability, right? We have to be also sensitive that there are going to be barriers for them, that are unique to their intersectional identities. Okay. So, trauma-informed care in medical settings. So I really like this pyramid because it helps remind me like really the meat of it, the important parts of trauma-informed care is really having to do with patient-centered communication and care, right? So excellent patient-centered communication. It's really like specific communication behavioral techniques that we use to help reduce anxiety and increase that physician rapport. It does not require that you know someone's personal history, right? And I can't underscore that enough, right? So you can think about this as like, we're trying to utilize universal trauma precautions, because really the truth is like, you just don't know what someone else has been through, and you may not know what your colleague has been through. You may not even be totally consciously aware what you've been through, So, so we're trying to adopt these precautions in medical settings. So, especially because they're more likely to feel out of control in those settings. Healthcare providers can find ways to offer patients control or share their priorities and be transparent. Like, so for like in a physical exam, one can, you can like give them a heads up as to like what body parts are going to be involved in the physical exam. You can always allow patients to ask questions, give them time to ask questions afterwards, offer them choices of what clothing can be worn, versus like a gown if that's really uncomfortable. What can be done in the room to make it more comfortable for them? Is it okay, like maybe they can sit closer to the door, leave the door ajar or closed, but really telling someone, oh, you don't have anything to worry about is not the same as empowering someone to share their concerns or discuss coping techniques. So the next level here is understanding the health effects of trauma. Right. So trauma, and I'll go into this a little bit more, what's actually happening somatically for folks, but really what you're going to see as like a healthcare provider, so you're going to probably see the effects of maladaptive coping techniques, right? So that might be engaging in like substance abuse or smoking, disordered eating, high-risk sexual behaviors, workaholism, sometimes all of those things can have adverse health effects, and we may be treating that. So secondly, understanding ACEs. I don't know if you folks are familiar. I'm sure you probably are familiar with ACEs. I'm just assuming, but adverse childhood experiences really is known to kind of, or has been connected with having chronic hypopituitary adrenal axis activation, which can lead to chronic health conditions or shortened lifespans, as well as epigenetic mutations. And so you may even see intergenerational transmission of serious medical conditions because of traumatic experiences that are being held by these populations. So really, us as providers, it's really important for us to be sensitive to that. Migraines in a child, it's not very common, but especially you're seeing it in a long line of family members, that may be because of intergenerational trauma. So this this diagram, I really like this kind of summary. It's kind of showing, right, some of the pathways that mediate exposure to early adversity and adult outcomes. So exposure to adversity early in life, so at these really like sensitive periods, right? So in this, in postnatal period or infancy, around 15 months where they're having language acquisition, and then 24 to like 48 months where they're really developing their attachment and solidifying their acute. These exposure to adversity early in life will interact with the child's genetic endowment, right? So you're going to see variations in genetic polymorphisms, which can lead to a host of biological changes across multiple levels. So, and then these changes, right, you're going to see the epigenetic changes, you're going to see neurodevelopmental disruption, and you're going to see also reprogramming of like the stress response. So you're going to see chronic inflammatory disease processes that are taking place, and this can be also linked to early childhood adversity or multiple levels of adversity. All of these biological changes can be further embedded, right, through those maladaptive coping techniques that we talked about earlier. So it might be their substance use or their level of physical activity, their diet, the ways that they cope with stress, right? So really deeply affecting adult outcomes in a very physical way, right? So asthma, COPD, kidney disease, diabetes, obesity, depression, and cancer definitely can be a result of toxic stress and ACEs. So in screening for trauma, so manifestations of trauma are really as unique as the individual, but they tend to have like these patterns, right? And you could think of them all as like a chronic sympathetic nervous system activation. The way that I explain trauma to like my patients, so when a traumatic event occurs, it gets recorded in your body, right? So it's like embedded in your body, and that memory is just reverberating in your body, and it's really sensitive to reminders. So anytime you come across a reminder of like the past trauma, it's like trying to bubble up, right? And since that trauma takes place, there's like a disconnect, right? Because you're trying to avoid those memories. You no longer feel safe in your body anymore, right? So there's a lot of avoidant behaviors, a lot of numbing behaviors that are taking place to try and keep running, keep going, keep minimizing the chances that you'll re-experience that trauma. So it's really hard to tell someone, oh, just go to therapy, because not all therapies are really going to address that somatic component of trauma, right? You can't really cognitively think your way through trauma. It's a very much a somatic experience. And so the path to healing is to learn to relate to your body or to connect with your body, form those connections again, but like you're teasing your nervous system to grow in a different way and to use different pathways. So healing from trauma may look like yoga, it may look like acupuncture, it may look like dance, it may look like body work, it may look like all kinds of things. It may look like EMDR, which is, if you folks aren't familiar, but like a specific type of trauma therapy that can be really effective for recategorizing those trauma memories. So I give people a roadmap to healing, but like the medications may or may be somewhat of a support, but really the roadmap to healing is much bigger, and it really can't take place until people are feeling somewhat more stable or safe environmentally to be able to do that work. Right? But there are definitely things that we can do in the meantime. So things that we as providers are looking out for, complaints of like irritability or aggression, complaints of having low energy, or low self-esteem, low lack of interest, problems with focus. They may be really complaining of like brain fog, nightmares. Nightmares for me is a pretty helpful kind of way for me to suss out if someone has like PTSD or chronic PTSD. of course, like drug and alcohol use and any kind of efforts, to like avoid situations, or if they're feeling like always restless or feeling hypervigilant, unsafe in public or around people. But they might have like other somatic complaints like chest pain or nausea, chronic body pain as well, has very similar kind of manifestations as chronic PTSD. So the 4 Fs, I just really wanted to like bring it up to you, but the 4 Fs for trauma responses, and this is helpful to keep in mind. So fight. So if someone is feeling triggered, they might get aggressive. Flight, they might want to run away. Freeze, they might feel really paralyzed or shut down. Or fawn. And fawn is the last one that people probably know the least about, but they may seem really happy and nice and like friendly to you, even though you may have triggered them. Because if someone is bullying you, or if someone is making you feel like you have no power, they still may be smiling to you. So you don't know necessarily that you have crossed a boundary and triggered someone until they just don't show up in your office again. So it's just wanted to keep in mind that the 4 Fs can be really helpful for categorizing trauma responses, but they may not be immediately apparent to us. So a big part of this work that we do as providers, like we show up every day for our patients, and it's really hard, at the end of the day. And so what we can do to kind of make this a sustainable practice for us is to really understand our own history and our own reactions to things. So whatever you can do, if there is a patient and you're finding that it's really hard to work with them, it could be really helpful to run that case with a supervisor, or to seek out your own counseling yourself, because they may be triggering something from your past that you may not have been aware of, or maybe something that you are very aware of and it's really hard and you may need additional support around that. So conversely, we may also be capable of like instilling harm on someone else, right? If we don't examine our own privilege, our own power differentials. And I put this little diagram here just to kind of understand like the context for what trauma is occurring, right? And sometimes helping people put their trauma into context can be a really healing practice. And so it's something that I use in my practice with people, is like, these are infrastructural manifestations of inequity. So colonization, politics, globalization, capitalism, war, etc., the immigration system, the education system, all of these are ways that these are like infrastructural forces that are set up in our society, and some people are allowed resources and other people are not, and that's determined through these different infrastructural forces. So you may experience like ableism or racism or discrimination or classism, not just like on an interpersonal level with someone one-on-one, but also through an institutional level, right? And so all of these are people's like unique identities, and they may have a spectrum of experiences, but it all contributes to how they are uniquely experiencing trauma on a day-to-day, and how and why they may be kind of showing up in your office, right? So I think kind of understanding that and doing the work to understand the contexts in which trauma inequity and health inequity are occurring are also a big part of the work that we do as healthcare providers. So all that to say, so learn the signs of professional burnout. I don't know anyone who's gone through the pandemic who has not been a little bit burnt out. If you have, like, what is your secret? I am so like, I really want to know. Please like email me later. But signs of burnout, lack of energy, depression, maybe using a little bit more substances, maybe having lots of headaches, maybe having issues with your sleep or with your appetite, maybe feeling like all the work that you do doesn't matter, you feel demoralized or you feel numb. all of that can really happen through the accumulation of the work that we do, all of the different experiences that we have with these individual clients or patients. And so it's really important to remember that part of our work is also practicing good self-care. That doesn't necessarily have to fall on our shoulders. It may mean our community. So if you're part of a community, it's okay to ask your community for support. I think we often it's easy to think that we're supposed to be responsible for our own health, but really that can also be a community thing. And I think it's okay to do that. All right. So interprofessional collaboration and integrated care. So I love the integrated care model. I think it's been really helpful in working at Refugee Health Alliance. I think that, on a base, like a part of this talk was originally structured for people who are just working in the shelters, right? So, but healthcare workers and honestly, anyone in any organization that you work can identify cases and connect them with mental health or social workers, right? But ideally, the referral is privately communicated. You're not talking in front of the patient or, an identified case about like the reason why they need help, right? But, and of course, anyone who's done medical school would kind of knows that you just how to like do like a short, case summary to ensure continuity of care. But us as healthcare providers, maybe it might be helpful to maintain like a list of referral sources, across disciplines for patients who do disclose trauma history, but maybe who aren't ready to like be connected. So I like to talk about, I just want to like mention that of course, I totally understand there are obstacles to integrative care. Like it's not possible across all settings, but at Refugee Health Alliance, like we have the like Western medicine aspect of our clinic. And then we have like midwives or parteria who also practice like holistic like care and provide acupuncture. We have our mental health providers who do individual as well as group, as well as go out to the shelters. And then we also provide food. We provide like showers and places where you can wash your clothes or get new clothes. And we try to refer to legal aid if necessary, so it's all very integrated, and we try to work really closely in building that alliance part up of our organization. But of course, again, these obstacles are very real, right? And a big part of them is like, maybe we're afraid we don't know how to handle a situation. So we may be afraid to ask like, what's really going on? Afraid that like, maybe once the dam breaks loose, you can't like, put all those emotions back into place, so we're afraid of creating a crisis. And of course, like integrative care as a whole, like a big part of it is big barrier is stigma. People are worried about how they'll be perceived, very often people with mental health issues were seen as disabled or less than in society's eyes because they can't supposedly contribute to society, and that is a really strong sense of ableism that's infiltrated our societal values. So uses for psychological first aid. So I think it was really developed as like a post-crisis situation. So like a natural disaster, for example, but ideally, it can be used to promote safety. You can help stabilize the survivors. You can help reduce symptoms of stress, like find their strengths, and also ideally connect them to more resources. All right, so part one of psychological first aid. So active listening, or escucha activa. So breathe yourself. So take a deep breath, to transmit confidence and tranquility. So, and just start off with open-ended questions like, what can I help you with today? Your body language is really important. So like, turning towards someone versus turning away, or feeling like disinterested, is really helpful. Active listening also is not just like being quiet until they finish. It's also like paraphrasing what they tell us to reinforce that they are heard, right? You can also validate their emotions. So it's about understanding and not blaming them. And then reinforce what you hear. So that phrase, I understand that is very difficult for you, that these headaches do not let you rest, right? So that's a great example of how to like validate someone's experience. Well, lastly, the most important thing of active listening is actually a don't, but trauma-informed care means not asking people to repeat their trauma histories. Sometimes people will kind of like launch into it. I do like to preface people that like, hey, I don't need to know all the details. I know this is the first time you're meeting me. Like, you know, if there's a question I ask you, you just want to wait till later, like, that's totally fine. You know, you're in charge of that. So, yeah, but we try to be conscious that we're not being voyeurs of like their experience, you know. It's not necessary for us to be able to provide them with support. So one of the techniques for comforting and stabilizing people is like learning how to like ground them in their senses, or to like just teach them diaphragmatic breathing or belly breathing. So vamos a respirar juntos. Muy bien, vamos a respirar juntos. So when I say slowly take a deep breath in, I'm trying to like teach them. I don't know if you guys have seen like a baby sleeping, right? So when a baby's sleeping, it's like their abdomen is expanding, right? That's like total relaxation, right? So when I try to tell people to put like a hand on like their stomach and a hand on their chest, and really just focus on making the hand on their stomach expand or move when they take a deep breath in. And I ask people to breathe in for 3 and out for 4. And that mismatch, you know, less oxygen in is sending a message to your nervous system. I don't need that much oxygen. I'm actually safe. You know, I'm not trying to run away from something, you know. And breathing into your belly is activating the lower third of your vagus nerve, which is activating the parasympathetic nervous system, versus like if you're breathing up here into your chest, you're activating the sympathetic nervous system, like all of the branches that kind of encircle your heart, right? And so therefore you're sending a message to your nervous system, okay, we're going to redirect blood flow internally to digest that food, right, in parasympathetic mode. So you feel like the blood start to drain away from your muscles instead of filling them up. So which is what happens when we're feeling really tense, right? So I teach people this like almost every day in my practice, but it's very easy to teach them. I tell them to just practice it before they're going to bed, you know, and it gets easier to like use during the day, just to like reset your nervous system so you're not constantly ramping up, right? But if they're feeling really, or they're looking really like really overwhelmed, you can kind of use this to see as like a grounding technique. The other grounding technique is to use people's like 5 senses. So try to get them to like activate those senses, and it helps them from like detaching or dissociating in the moment, right? So ¿cuántas cosas azules ves atrás de mí? So how many blue things do you see behind me? Okay, ¿qué puedes oler en este cuarto? What do you smell in this room? ¿Cuántas cosas puedes oír ahorita? So what can you hear en el cuarto o afuera del cuarto? So in the room or outside the room, what do you hear? So trying to get them to activate these different senses can be helpful to grounding them. So next part is a needs, and psychological first aid doesn't necessarily go in this order, but I'm just kind of explaining all the different elements of it. But a needs categorization can be really helpful. So I understand that you need blank and blank, right? Entiendo lo que quieres es blank and blank, correcto? So I refer to needs as like in a general sense, not like, oh, you need like medication for something, right? Ayuda para dolor de estómago instead of medicina para dolor de estómago, right? So it sounds like your priority is getting to sleep. So one of my colleagues can help with that. So you're starting to introduce like the bridge to like another resource, right? Suena que quieres ayuda para dormir. una de mis compañeras puede ayudarte. And referrals also, like, not necessarily to like other providers, but you can also think of like referrals to people, like to try and activate their support network. So who in your network can support you more? So if they're like living at, like, if they're unhoused and they're staying at a shelter, you know, is it the shelter director or case manager or neighbor or any of the people in their phone, right? ¿Quién en tu red puede apoyarte más? Who in your network can help you more, right? And I don't really say psychologist or therapist, you know, if I'm talking about my referrals, I just say compañera or colleague, you know, kind of roughly translates to colleague. So again, when you're making a referral, we're not trying to do that handoff right in front of them necessarily, you know, try and do it like, talk about the background details, right? Like, let's say you learned that this patient recently suffered from a sexual assault and one of her children was murdered. So I'm not going to say that right in front of my patient, you know, like I'm going to kind of talk to the person, but I still can do the warm like introduction in front of them, you know. So ideally in an integrated care setting. So you bring that social worker, the psychologist, psychiatrist, or whoever it is to your office to do that. So psychoeducation is like a big part of it. Really trying to normalize symptoms. So symptoms are common response. So you aren't alone. These symptoms are common responses to trauma. So let's say they're having issues with like insomnia. So although staying awake helps you stay vigilant, right? They may not feel safe enough to go to sleep at night. The body needs time to rest, in the very least a few minutes, right? So we're repeating back what's happening and the pros and cons of it. So medication, listening to a guided meditation, or talking to someone are things we can try to help you gain more rest. You do not have to tell the therapist what has happened in your life. They will respect your privacy. So again, trying to be really transparent with them. And then you as a provider, you can consider, if you feel comfortable, explaining how medications, I say they can help alleviate stress or help your body to heal from stress. Sometimes we refer people to acupuncture, which can help release feel-good hormones like endorphins and improve circulation and oxygenation of tissues, right? So. All right. So ways to kind of increase self-efficacy, ways to kind of validate their experiences, you know. So I always thank people for sharing their story. I think it takes a lot of them to do that, to feel comfortable enough to trust me. I know sometimes we take it for granted, I think, as providers, because, well, like, we're here to help you. Of course, you're going to tell me everything. But like, honestly, it's really, really hard for them to do. So I'll tell them, you know, te admiro para estar tan valiente de compartir esto conmigo. So I admire you for being brave enough to share this with me. Gracias por estar abierto a hablar sobre esto. Thank you for being open to discussing this, you know. So, and I can see you can also like point out their strengths. I can see that you are someone very strong because you have survived so much. Here you have a team that you do not, so that you do not feel so alone in this. Me and my colleagues can work with you to find more ways to deal with these issues. So like kind of explaining that we're in this together. And I just thank them for being patient. So I just have a few slides on motivational interviewing. So I want to make sure I leave enough time for discussion, but sometimes when there's ambivalence, it's helpful. Motivational interviewing is like you can take like a whole course on certifying for it, but I think like some key takeaways you can probably still use in terms of like active listening. So the basics are just like what we talked about already, like active listening, like open-ended questions, repeating back, you know, just trying to be like investigative and like really like listen to understand, right? Not listen to judge, right? And summarizing back what they say, use their own words, you know, so that they really hear that you were listening, right? And then review the positive and negatives based off of what they said. in regards to making that certain change. So motivational interviewing, what I'll do is like, okay, between 1 and 10, how motivated are you to make this change? You know, entre 1 a 10, ¿qué tan motivación tienes para cambiar? And let's say, I'm a 6. And so I say, okay, so if you're a 6, why not like a 3 or like a 1? Like, and so they start to kind of tell you like the reasons why they aren't, like the positives of change, like why they would be motivated, right? And then I ask them between 1 and 10, how confident are you that you will make this change? Entre 1 a 10, ¿qué tanto confianza tienes que vas a cambiar? So maybe they'll tell you like, I'm like a 4, right? I'm not really that confident. I was like, okay, but it's a 4. Why not isn't it a 0? So like, again, trying to encourage them to talk about the positives, you know, like the things that they recognize in themselves. They could help them get to that point of change. So, but we can still offer, even if they don't want to change, you know, before going to sleep, I would like you to imagine this. You can have like an image on your phone, you know, imagine this image. Antes de dormir, me gustaría que imagines esta imagen. So, or you can say, okay, when you go home before eating, I'd like you to take 5 slow, deep belly breaths, you know, and maybe you can offer them some links to guided meditations online at Refugee Health Alliance. We have some audios that we created and we like send those to our patients over WhatsApp. Or we can give them a phone number to use when you need more support. So local crisis lines in California, this is locally California Youth Crisis Line. And then I always tell them we're always here if you need more support to deal with stress. And here are just like some basic resources. I'm sure you guys know this, but everything here is in Spanish. So I have some like one example. I know we started a little bit late, so I can kind of go through just like a few slides if you want, but I can introduce it and see how far we get. So here's just one example of like this patient that's having issue with nausea. Sorry. How can I help you? The patient, I have a lot of nausea, I don't have any appetite, right? So you as a healthcare provider, so you conduct your interview, your physical exam, it appears that the stress or drug use is worsening this patient's symptoms. So what do you ask them, what do you do before eating or before these episodes of nausea? And the patient tells you, maybe they tell you like, oh yeah, I'm smoking to kind of help me relax before I eat. And then maybe they're telling you, I'm thinking a lot about my past and what I should be doing for my family. So in this example, so you can demonstrate active listening by saying, so I understand that this nausea is impacting you a lot. So you're validating their experience as well, right? But yeah, you're right. Your weight is very low for you and you have, you know, let's say they complain of other symptoms, right? And then you can say, I understand that your situation comes with a lot of stress and that you're doing what you can to help yourself and to help yourself relax and help your family. Oops. So active listening again, validation of experience, right? But in fact, before eating, these stressors can make your nausea worse. So you're trying to show them, you're trying to introduce a little bit of psychoeducation that the stressors are probably contributing, or the cannabis maybe is probably contributing to the nausea, right? So I have a colleague who's very knowledgeable about other strategies to help relax and feel safer before eating, and maybe to help lower levels of stress and increase your appetite. Would it be okay if I connected you with her? So starting to introduce the interprofessional collaboration, right? Patient is like, I'm kind of ambivalent. I'm not sure. I don't want to talk much about it. I just want a medication to make it better. And again, you as a healthcare provider can try to educate. I understand you don't want to talk about it. In fact, you don't have to talk about anything you don't want to talk about. I'll tell her that you want help with the nausea and she can help you with some options. And you would only need to listen and you don't need to talk. So again, giving them that power back, right? Reinforcing with trauma-informed care. And then I'm talking to the therapist, or what are they going to show me? Good question. So I always say like, oh, I really like your questions. You know, I try to encourage them to feel comfortable asking questions. I'm glad you're asking good questions because it shows you're taking charge of your health. I can show you a basic strategy. Like, so then maybe we first note how your stomach feels now. And then let's breathe together slowly from our abdomen 3 times and take notice of how your stomach feels now. Is it more stressed and tense, or is it more soft and relaxed? So breathing together is a big part of that comfort and stabilization too, right? The patient is like, okay, maybe it feels a little less tense, you know? So again, like, you did great. This shows me that my colleague can show you how to use other techniques. So really trying to encourage them to take ownership of that and work with the colleague again. So you show you how to take charge of your health so you can feel better. And again, cuando son dudoso, if they're doubtful or ambivalent, you can also use motivational interviewing. So entrevista motivacional. So I don't want to stop using, let's say if it's cannabis, it's the only thing that relaxes me. And I bet the therapist is going to pressure me, says the patient, right? But you as a medical provider, I understand you want to find ways to relax. I can tell the therapist to respect your decisions. And what I'm hearing is that you want to feel less nauseous. So how motivated are you on a scale of 1 to 10 to decrease your symptoms of nausea? So let's say 10 is the most motivated. Patient says, maybe 7. You as a medical provider, great. Why is it a 7 and not a 3? Well, like I told you, I have lost weight. I'm worried that I'm going to keep losing weight. You as a medical provider, yes, it's very important to try and stay healthy. How about then we collaborate with my colleague to help you with nausea? Okay. Ideally, it would probably go about as quick as that, but it doesn't always, of course. But anyways, mil gracias to everybody. I'm open to questions. Here's my contact information too. But yeah, I'm not sure if that was helpful. Hopefully it was.
That was so wonderful. Thank you so much, Dr. Anaya. I love that you gave such concrete examples. I think for many of us, I've heard probably dozens of talks on trauma-informed care. And I think in the abstract, we all are familiar, but to actually put grips to it and examples of how you can actually apply this, particularly the Spanish translations I found really helpful. So thank you. That was fantastic. I invite anyone to unmute themselves. If they have questions, you can raise your hand or feel free to straight up unmute or type any questions into the chat. I can get us started with one burning question I have, which is, what resources do you recommend as far as free tools that patients, particularly Spanish-speaking patients, can use online for self-skill building?
For skill building, that's really interesting. That's a really good question. So for when we're working at Refugee Health Alliance, a lot of the psychological first aid techniques we've also put into like audio files. And so that, I think I referenced it earlier, like that's how we kind of distribute like guided meditations, like muscle, like muscle relaxation, like guided meditations, like techniques and to help you get to sleep better, those kinds of things, imagining a safe place. And so those are kinds of things that we try to reinforce with our patients. I think for online, you know, I was kind of like looking into like things that we can use. This is like an image taken from like this first YouTube link. And I just like looked up like in Spanish, like progressive muscle relaxation in Spanish. And they have like lots of like videos that are already created to kind of like people can just like listen to as they're like going to sleep and stuff. So, so I think that's part of it. NAMI, you know, you folks know, I don't know if everyone is like familiar with NAMI, but they have like a chapter like everywhere you go in the United States. And so they're really great at creating like groups, online groups, especially since the pandemic as well, to help create support. Cal Youth Cycle, I don't know if you guys are familiar with that one, but that is like online text, like you can text, like kids can text like for support. So it's like kind of like a lot of kids are like much more comfortable like texting rather than like picking up a phone to like talk to someone. And so yeah, that website at the bottom is really great. And that phone number, you can text that phone number basically. And then you'll be connected with like a person there. And it's in Spanish and English. So but yeah, unfortunately, like all of like LA County started like I Prevail. I don't know how good it is. Like I tried to kind of fuss around with it and it was, I don't know, it was like a little lame. But but I try to find and that's why it's kind of important to kind of like know your patients. Like if they're queer, like I really try and connect them with like queer resources like the Trevor Project or like suicide prevention for LGBTQ people and things like that. So
thank you so much. And I know I think we have folks from all across I think we have some folks from out of state joining us as well. So I do want to highlight, for those who aren't familiar, the 988 suicide hotline is now national. So regardless of where patients are, they can use that resource and it'll link them into the local hotlines. We have a question from Dr. Delgado. G-Man, did you want to unmute yourself or do you want me to read it from the chat?
Mute. Thanks for taking the time to speak with us. I think obviously mental health has been such a big need in the outpatient world, especially since pandemic, and of course with these kids. And as a primary care doctor, it's sometimes hard to know what to do with the in-between time. In between meaning when you identify that patients need more care, but then maybe their referral to behavioral services will take a few months. And so, wanting to, of course, give them support and maybe give them some of those skill sets we're talking about, I wasn't sure how often is appropriate. And I was thinking each individual case is different, of course. But is it like weekly, monthly, like how closely should we be following these kids until they get kind of more plugged into socialized services?
Yeah, that's such a great question. I will say, if it's like in a crisis, like probably weekly would be best, we always say like, okay, take your kids to emergency room if they have like suicidal ideations. Yes, on paper, yes, of course, that's the right thing to do. But like genuinely, like our inpatient health system is not the cornerstone of healing for like our patients, and sometimes can do a lot of can incur a lot of trauma on them as well. And so if you have space in your schedule to do even just like a phone check-in with them, if it's Friday, okay, I'll check in with you on Monday and then see how it's going. You can try and bring them in on Friday, I do see patients weekly if they're in crisis. If they're starting to stabilize, then you can push it out to bi-weekly or monthly, and it's fine until they get it. I think the average rate, is about 3 months to find a provider, which is tough, for sure. For a psychiatrist, a child psychiatrist, let's say. For a therapist, it's probably less to some degree. But yeah, it's a really good question. But I think them knowing that they have you to look forward to see is as a touch point is really helpful too. And being in communication with the parents, if they're permitting, would be great. Yeah.
Thanks.
Other questions that folks want to chime in with? So feel free to again to unmute yourself or type it in the chat.
Hi, thank you so much. I'm Karina. I have a quick question. So for patients, maybe if their trauma revolves around something that happened to their body, do you have any tips for TIC principles for the physical exam?
Yeah, so I think what I think I talked about it maybe in the very early slides, was giving them a heads up of what the physical, what body parts are going to need to be exposed first. So okay, so I'm going to need to see underneath your shirt, you know, we have a gown, or you can keep your shirt on and then we can do it in pieces, like what feels comfortable to you. So really like, you know, giving them a sense of control over the process can be really like helpful to them, so they can like pick and choose and can see you as a safe person, I think is really important, you know. But yeah, asking for permission, asking for consent along the way is also really, really important, I think. But that's a really good question. I hope that helps clarify for you. Is there anything else more specific that I missed, or no? Okay.
Others who have questions? I have one more I wanted to pose that I see quite frequently in my outpatient clinic. And that is, I've been running into a lot more recently of teenagers who are very motivated and ready to participate in therapy, but maybe their parents or family are not as comfortable with the idea, or might have community or cultural attitudes where therapy is stigmatized. How do you navigate those types of situations? Do you have any pearls to share there?
Yeah, definitely. I mean, you can probably try to talk to parents like alone, just because they may feel like also like more empowered in that setting. Like they may not know what's going to come of it, or they may worry about privacy, or they may worry about, yeah, how they're perceived and things like that. So you can answer any kind of questions having to do with like, you know, whether it's discreet or not, but what the goals are. And usually what I try to explain to families is like that your brain and your body are like super connected, you know, so, and they may keep having like physical manifestations of stress, and it doesn't make it less real. But if we start to learn some techniques from some therapists to help lower stress, then it makes your life better, because then you're coming to the office less, you know. So I try to identify like patients, like the parents' goals, like for their own kid, and try to speak to that, you know. It's like, how do we get you what you want, you know, like, and really kind of put it in those terms for them. So yeah, but children can consent to their own therapy, like above 12.
Right.
So it's like, it is like complicated, you know, but there are, I recently started talking to like this one organization that is focusing on like queer and trans kids right now, that is like offering to pay for therapy for kids who don't have parental support. So it's like a pretty, yeah, I think it's a pretty amazing kind of like idea. So I'm kind of excited for them to kind of get going. They're called Safety.
That's wonderful. Yeah, I think the challenge, at least where I practice, is obviously on paper these kids can consent, but I think in reality, when I've tried to do it directly with the kids, there's so many barriers between transportation and sometimes misinformation with registration as far as needing parent consent, proven to be harder than I wish it was, but it's definitely some helpful tips on how to maybe slowly work on getting the parents on board, which is probably going to make it a successful endeavor anyway.
Yeah.
Other questions? I know I want to be respectful of everyone's time. We're right about at the 6:30 mark. Do we have any folks who have any questions remaining? Well, if anything comes up, feel free to message us. You can contact the AAPCA2 email, and we'd be happy to pass your questions along to Dr. Anaya or provide any feedback. We will be posting this onto the CA2 Immigrant Health Committee website. For anyone on this call that is calling in from Southern California, if you're not involved in this committee and you're passionate about this topic, please join us. Also, if you're in Southern California, RHA, Refugee Health Alliance, is an incredible organization and a great way to give back and work directly with communities who really need it. So please consider checking out both the RHA website, our website, and thank you again so much for generously donating your time and being here with us today, Dr. Anaya.
Yeah, thanks so much. I appreciate the opportunity very much so.